follow patient of esophageal cancers. For follow-up, in case of squamous cell carcinoma, we do, if asymptomatic, every 3 to 6 monthly for 1 to 2 years, we will ask the patients to come for follow-up. And then after 3 to 5 years, we will ask the patient to come for follow-up every 6 months to 12 months. We'll do CBC, and then biochemistry, imaging studies are done, then endoscopy, biopsy if clinically indicated, dilatation of the anastomotic stenosis, and nutritional assessment and counseling is done. If there is any evidence of locoregional recurrence and prior esophagectomy was done, or there was no prior chemoradiation, then we can plan for concurrent chemoradiation, or we can again go for surgery or systemic therapy based on, or palliative care based on the performance status and the status of the lesion. Then response assessment is done by CCT chest abdomen with contrast. If there is recurrence, then we patient keep on palliative management. And if there is locoregional recurrence and patient has received prior chemoradiation, if it is resectable, metabolical and medically operable, then we will go for esophagectomy. Then we'll keep this patient on follow-up for with the chest abdomen CT with contrast, and if it is recurrent, if there is any evidence of recurrence, we'll keep this patient under palliation. And if it is unresectable disease, then palliative is the management. In case of metastatic disease, we'll keep this patient for palliation. Now, if the patient is unresectable, locally advanced or metastatic disease, we'll see first the Karnofsky performance status of this patient. If it is more than 60% or ECOG performance status is less than or equal to 2, then this patient is performed for MSI testing and PD-L1 testing if not done previously, and NJ should be considered via validated assay. Based on this, patient is planned for systemic therapy and or palliative or best supportive care. If the patient's performance status is less than, Karnofsky performance status is less than 60% or the ECOG performance status is more than or equal to 3, then patient is placed on best supportive care. Now what about the adenocarcinoma? For adenocarcinoma, staging stage 1 to 4A locoregional disease, except in case of T4B disease and N3 disease, we do multidisciplinary evaluation. Consider for enteric feeding tube for preoperative nutritional support. Laparoscopy is done, which is optional if no evidence of M1 disease and tumor is at the esophagogastric junction. If the patient is medically fit for surgery, then what we have to do, and if it is non-surgical candidate, then what we have to do, we'll see. So celiac nodal evaluation involvement in cancer of GE junction or distal esophagus may still be considered for combined modality therapy. So this is an important point. Percutaneous gastrostomy tube may be considered for patients with cervical esophageal tumor receiving definitive chemoradiation or patients with marginally resectable disease. Multidisciplinary expertise is recommended prior to placement of percutaneous gastrostomy tube. To approach timing and location of the feeding tube should be discussed with the surgeon prior to its placement. Medically unable to tolerate major surgery and patients who are medically unable to tolerate major surgery. So in case of adenocarcinoma, if this patient is having TIS T1A tumor based on ER resection, so if it is PTIS, in this case we can prefer endoscopic therapies like endoscopic resection or ablation, and then keep this patient for endoscopic surveillance, or we can go for esophagectomy, surgical resection. And in case of T1A lesion post ER endoscopic resection, can go for endoscopic resection with or without ablation or esophagectomy. And for T1B lesion onwards, we'll go for esophagectomy, which is preferred. And in case of N plus disease or T1B, T4A or T4B disease, we'll discuss later what we have to do. So initial diagnostic endoscopic resection procedure may prove therapeutic for some patient, but for others additional therapy may be necessary prior to the start of surveillance. Now, preclinical staging cannot establish the number of positive nodes. For selected patients, consider endoluminal stenting when appropriate. Transhiatal, transthoracic, minimally invasive gastric reconstruction is preferred. Feeding jejunostomy for post-operative nutritional support generally is preferred. A diagnostic endoscopic resection can be considered to confirm the pathological staging and for treatment in selected patients. Endoscopic resection followed by ablation that may be used to completely eliminate residual dysplasia or Barrett's epithelium. Esophagectomy is indicated for patients with extensive carcinoma in situ like TIS or high-grade dysplasia, T1A, superficial T1B. So esophagectomy is indicated for patient with extensive carcinoma in situ, TIS or high-grade dysplasia, T1A lesion, T1B lesion, especially nodular disease that is not adequately controlled by ablation or endoscopic resection followed by ablation. So definitive chemoradiation may be an appropriate option for patients who decline surgery. So if it is adenocarcinoma, clinically T1B, T2, N0, low risk less than 3 cm, well differentiated tumor, esophagectomy is the option, and we'll see surgical outcome after esophagectomy. But if it is T2N0, high risk lesions more than 3 cm, LVI present, poorly differentiated, or T1B, T2 lesion, N plus disease, or T3, T4A, any N, we have to plan for perioperative systemic therapy. So size, LVI, and its grade, T2 N0. So these are all high risk lesions. LVI positive more than 3 cm, poorly differentiated, T2 N0. These are high risk lesion. T1B, T2, if it is N plus, it is also high risk. And if T3, T4A, in case of T3, T4A, we'll plan perioperative systemic therapy, which is category 1 recommendation, or we can go for perioperative chemoradiation, or consider neoadjuvant or perioperative immune checkpoint inhibitors if tumor is MSI high or MMR deficient, or definitive chemoradiation only in patient who decline surgery, or definitive chemoradiation or consider chemotherapy alone in the setting of invasion of trachea, great vessels, heart, that is palliative management. So preclinical staging cannot establish the number of positive nodes. We have seen all these things. Now perioperative systemic therapy, which is category 1 recommendation in case of adenocarcinoma, T2 high risk lesions or N plus disease, or T3, T4A disease. Initial assessment is done by response assessment is done by PET CT or CT chest abdo with contrast, IV contrast, and esophagus duodenoscopy, biopsy. And if there is no evidence of disease, or if there is persistent local disease, we have to go for esophagectomy. And if patient declines surgery, then definitely chemoradiation is planned.